Okay, then I would like to invite our next speaker up to the podium, which is Kelly Bolton, and she will talk about impact of oncologic therapy on clonal hematopoiesis.
Hi, thank you. My name is Kelly Bolton. I'm an instructor at Memorial Sloan Kettering in the leukemia department, and I'm a member of Ellie Pop Emanuel's lab, and I'll present today on work that I've been doing looking at the impact of oncologic therapy on clonal hematopoiesis in solid tumor patients at MSK. So as Ben and others have talked about in previous sessions, the reason why we care about clonal hematopoiesis to a large extent is because as oncologists, we're concerned about the progression to leukemia. And this is particularly relevant for solid tumor patients because they're at a higher risk of secondary leukemia overall. In particular, they have higher rates of therapy-related myeloid neoplasms. And here I'm showing data that was taken from a paper using SEER data to look at the rates of secondary leukemia, and you can see that overall, most patients with solid tumors are at higher risk of secondary leukemia, and the rates vary depending on the oncologic therapy that they get. At MSK, we have a really unique ability to study how clonal hematopoiesis is related to oncologic therapy because we have now over 30,000 patients who have been sequenced using tumor and blood as a matched control. And this is an opportunity to look at this in more detail. And the reason why we would want to do this is because since we know that oncologic therapy is related to myeloid neoplasm, and we know that clonal hematopoiesis is related to the development of myeloid neoplasms, understanding this relationship between oncologic therapy and clonal hematopoiesis might offer opportunities for prevention of secondary leukemia, which is really how we would most adequately treat this disease. So at MSK, we had previously looked at clonal hematopoiesis using patients who had been sequenced on IMPACT. I'll get into that a little bit in more detail later. But we found that it was very common in solid tumor patients and that it had a unique mutational distribution. So we saw an enrichment of patients that had mutations in PPMD, TP53, and CHEK2, and we thought in this paper that it was likely related to oncologic therapy. Since then, there have been several other groups that have published papers on both how CH is related to secondary leukemia risk and how oncologic therapy is related to clonal hematopoiesis. And so others have shown that, that getting continued therapy if you have CH seems like it increases the VAF of the mutations, reflecting the increased clonal burden. And others have shown that solid tumor patients who have clonal hematopoiesis are more likely to develop secondary leukemia than those who don't. But we didn't know what specific therapies were related to clonal hematopoiesis, whether there was specific gene treatment interactions, and whether oncologic therapy could cause, in some cases, or would mainly promote the growth of CH clones. And all of those have implications for the development of preventative strategies. So at MSK, in addition to having the tumor sequenced on IMPACT, the blood is sequenced as a matched control, as I mentioned previously, and this allows us to identify CH. As I mentioned before, we did CH calling in 24,000 patients who were sequenced up until July of 2018. And our main question was whether treatment related that was received prior to blood draw was related to the likelihood of having CH at the time of IMPACT testing. I won't go into detail of how we called CH, but I can address that in questions. But essentially, we use the tumor and the blood and a pool of internal controls to identify variants that are likely somatic in the blood after filtering out artifacts and likely germline variants. Among patients who had IMPACT testing, most did receive some kind of therapy prior to blood draw for IMPACT, but 40% were untreated. There was a good variety of treatments that were received prior to IMPACT testing, allowing us to look at all the major classes of chemotherapy in relation to risk of clonal hematopoiesis. Overall, we saw that around 18% of our patients had clonal hematopoiesis, And you can see this characteristic increase in the prevalence of clonal hematopoiesis with increasing age. And among all age categories, there was a slight increase in the proportion of patients who had clonal hematopoiesis if they received treatment prior to blood draw, as opposed to patients who were treatment naive. In a subset of patients who were sequenced on impact, I had access to germline information on high penetrance cancer susceptibility genes. But because each of those individual genes were pretty rare, even in this large cohort, I bend them into functional categories. And after doing this, it looked like patients who had a high-risk DNA damage response gene mutation, this is mainly patients with germline TP53 mutations, had higher rates of CH as opposed to patients who were negative for high penetrance germline susceptibility genes. And we saw this to a lesser extent with patients who had medium penetrance mutations in CHEK2. So in summary, for this first part, just describing CH, we see that it's associated with age and solid tumor patients, that CH in DNA damage response germline genes might be associated with oncologic therapy. But how is CH related to specific classes of therapy in our cohort? So I looked at the major classes of oncologic therapy, radioisotope therapy, which was mainly patients who were getting radioactive iodine for thyroid cancer, external beam radiation therapy, cytotoxic therapy, targeted therapy, and immune therapy. And a lot of patients got multiple classes of therapy, so I looked at this both in terms of patients who'd received only one of these major classes and multiple classes. And you can see that patients who received radioisotope therapy or external beam radiation therapy, both either individually or in combination with other treatments, had higher rates of clonal hematopoiesis, as with patients who received cytotoxic therapy. But we didn't see any association between receiving targeted therapy or immune therapy with higher rates of or different rates of clonal hematopoiesis. So going into cytotoxic therapy in a little bit more detail, I then looked at how specific subclasses of cytotoxic therapy might be related to rates of CH. And as reflected in the epidemiologic literature for risk of TMN, we saw that platinum and topoisomerase II inhibitors were associated with higher rates of CH. Because a lot of patients had received platinum and topoisomerase II inhibitors, we could look at to see if there was evidence of dose-response relationships within those major classes. And we saw that among patients that received higher rates of platinum, that was associated with even higher likelihoods of having CH, and the same, it was borderline significant for topoisomerase II inhibitors. Platinum-based drugs were the most commonly prescribed drugs in our cohort, and the three major drugs that were given were carboplatin, cisplatin, and oxaliplatin. And even within those drugs, you can see evidence of heterogeneity, with carboplatin having more of a stronger association with CH than cisplatin and then oxaliplatin. And even within individual drugs, you see evidence of dose-response relationships, particularly with carboplatin. Since most oncologic therapies aren't given individually, they're given in combination, in a subset of patients who I had information on what specific regimen was given, I looked to see if there were specific regimens that were more strongly associated with CH than others. And as you can see, the drugs that really fell to the top and that were most strongly significant were either drugs that contained a platinum-based agent or topoisomerase II inhibitors or a combination. We did see evidence of gene-specific interactions. Patients who had mutations in PPMD, TP53, or CHEK2, all genes involved in the DNA damage response pathway, had strong associations with having received those high-risk classes of oncologic therapy. So in summary, for this second part, we saw that CH was associated with prior exposure to radiation, radioisotope therapy, platinum, topoisomerase II inhibitors. We saw evidence of dose-response relationships, again, strengthening evidence that this is probably a real association. And we see that CH and DNA damage response repair genes seem to be the most strongly associated with receipt of oncologic therapy. So the next question we wanted to answer was whether patients who had clonal hematopoiesis, if we could show evidence that continued receipt of oncologic therapy led to continued growth of these clones. So in 400 patients who had CH that was identified on impact, we got a second blood sample at least 18 months after the first blood sample. We identified 500 mutations, and most of these mutations were seen both during the pre and the post blood sample. Our main question for this was just to look at whether oncologic therapy received during that follow-up period was related to the change in the VAF of the very little fraction of the mutation, suggesting an increase in the clonal burden. So this was done using a pragmatic design, just as patients were coming in to get a second blood draw. Often for the routine oncologic care, we just tagged on a research blood draw. So we had a lot of different types of solid tumor patients receiving a wide variety of oncologic therapies, and some people did receive no therapy during that follow-up period, and that served as our control group. So you can see here I'm showing plots of just the overall landscape of changes in the VAF for different mutations observed by what kind of therapy the patients had received during the follow-up period. And you can see evidence of both positive and negative selection for these clones. But in general, we saw a trend towards more growth in patients who are receiving cytotoxic therapy as opposed to patients receiving targeted therapy or untreated patients. And also we saw that patients receiving radiation therapy were more likely to have growth of these clones. And in particular, if you divide this into patients based on the type of mutation they had, again, patients that had mutations in PPMD, TP53, and CHEK2 genes that are involved in DNA damage response, we saw that those clones in particular seemed to grow in response to receiving oncologic therapy, whereas mutations in other genes showed much less of an effect. And again, kind of echoing what we saw in the retrospective part of this study, we saw that patients who were receiving platinum or topoisomerase II inhibitors or external beam radiation were more likely to have their CH mutations expand during that follow-up period, especially if they had mutations in PPM1D, TP53, and CHEK2, whereas we saw no such expansion in patients receiving targeted therapy. And just as we saw dose-response relationships in the retrospective study, in patients who received higher doses, cumulative doses of both radiation therapy and cytotoxic therapy, we saw increasing rates of growth in CH clones. So in conclusion, we found that CH was associated with aging, possibly germline genetic variation, and oncologic therapy in solid tumor patients. We saw evidence that this association between CH and oncologic therapy seemed to promote the growth of pre-existing clonal hematopoiesis clones. And I think the fact that we saw that specifically oncologic therapies that are known to associate with secondary leukemia also seem to promote CH suggests that this really could offer an avenue for identifying patients at high risk of therapy-related leukemia and possibly chemoprevention strategies for those patients. I want to thank Ellie Papa-Manuel, who's been my research mentor during my postdoctoral period, and all the members of her lab, and all of my external collaborators at NCI, and the folks in the clinical bioinformatics team at MSK who have really helped with a lot of the informatics of this project, and the CH clinical team who have helped us to take the first step in translating these findings into clinical action. So thank you.
Okay, so the floor is open for questions. Yes, please.
Hi, I'm Yazaki from Japan. Very nice work. Thank you very much. You showed that the clonal hematopoiesis was more frequent those who received radiotherapy, including radioisotope treatment.
Yeah.
Did you find double-strand break-related changes such as deletion or translocations in clonal hematopoiesis population?
Yeah, so we looked to see whether, so you're asking essentially, did we see differences in the likelihood of seeing an SNV versus a deletion or an insertion in patients received? So we didn't actually, which was surprising because of literature suggesting that you're more likely to have indels after being exposed to radiation. But in this setting, it seemed like besides the differences in the proportion of mutations that are affected, other than that, the mutational characteristics were very similar between treatment naive and treated patients. I think that supports the idea that oftentimes these clones are pre-existing prior to receiving therapy, that they weren't actually induced by therapy, but rather they were then selected for like clonal outgrowth when they received therapy. That's a really great question.
Thank you.
Thank you.
Got a question down there as well?
Yes. Uli Steidl, Albert Einstein, New York. There was a terrific talk, really very impressive work. I was wondering about the cutoff that you mentioned briefly. So you're using the 2% variant allele cutoff, broadly speaking. But biologically, there's no real reason, right, to pick 3, 2, 1%, even lower. And I was just wondering whether you've played with different cutoffs, and let's say if you just were to go to, let's say, 0.5%, 0.1%, even lower, would you? I mean, do you see the same things? I mean, one would assume even if a clone is really small, you would probably, I mean, see similar things with regards to pre-post therapy dynamics. And I was wondering if you've looked into this. So
the way that we, this data was generated from clinical sequencing. And so we weren't able to look at deeply subclonal events just because of the nature of the sequencing method that was done. But it would be really fantastic to do what you're saying, to be able to look at mutations that are at even more lower levels. And in order to do that, we would need to use unique molecular indices. And we were designing a panel to be able to do that. And you're absolutely right that it's essential that to understand this biology even better, to be able to sequence deeper with accuracy.
Great. Thank you.
Thank you.
Kelly? Here. Did you open a clinic for patients with clonal hematopoiesis?
Yes. Yeah, so we, at MSK, and others have done as well, we opened a clinic where I see patients that have clonal hematopoiesis, identified usually incidentally, either through impact testing or through commercial testing, or often through workup of cytopenias.
How many patients are you following now?
So I've seen about 100 patients in a year. So it's a very small clinic. It's very subspecialized. But as more and more clinical genetic testing is integrating into normal clinical workflow, the volume will probably continue to increase, and that's why others have opened clinics as well. Yeah.
Great.
Thank you.
Thanks a lot.
Thank you.
Yep.